Hola, es un placer daros la bienvenida a esta tercera edición del ACE Global Research Summit. Desde 1995, en ACE lideramos iniciativas que conectan innovación y sostenibilidad, trabajando en equipo para transformar el futuro de la salud y el bienestar global.
En la actualidad, somos una institución reconocida a nivel internacional, respaldada por un equipo interdisciplinario, multidisciplinario, de más de 100 profesionales.
Desde el principio, nuestro compromiso ha sido firme: transformar vidas a través del conocimiento y la innovación. Hoy hemos realizado más de 32.000 diagnósticos, más de 150 ensayos clínicos y tenemos más de 22.000 muestras biológicas para la investigación.
Esto nos ha permitido que en un solo año, el 2024, hemos publicado 60 artículos científicos en revistas indexadas de primer decil y primer cuartil. Estos logros representan décadas de esfuerzo en conjunto con la comunidad científica internacional y una dedicación constante para mejorar la vida de los pacientes y sus familias.
Y todo esto no sería posible sin un gran equipo, formado por personas excepcionales que encarnan nuestros valores. Por eso, en esta nueva edición del Global Research Summit, queremos celebrar estos avances y compartir los descubrimientos que están moldeando el futuro de la neurociencia, la práctica clínica y la investigación.
Bienvenidos al ACE Global Research Summit. Bienvenidos al futuro de la investigación.
Hello, and welcome to this final session of the Global Research Summit. I will introduce the meeting today on behalf of my colleague and friend, Dr. Mercè Boada, who is the Medical Director at Ace Alzheimer Center in Barcelona. It is a real honor to host this last session of our online summit, which has brought together leading experts in neurodegenerative research from around the world. Let me first describe our center. I will just translate into English what the video said earlier. At Ace Alzheimer Center, our mission goes beyond Alzheimer's research. We aim to integrate cutting-edge science and personalized care to transform the landscape of dementia diagnosis and treatment. Over the years, we have grown into an internationally recognized organization composed by a multidisciplinary team of over 100 professionals. Since our foundation years ago, Ace has become a pioneer in the field by diagnosing over 38,000 individuals and establishing one of Europe's largest memory clinics. In addition, we've contributed significantly to scientific innovation with more than 22,000 biological samples collected, very well phenotyped, I have to say, participation in over 150 clinical trials, and leadership in many research projects with global impact. As organizers of the Ace Global Research Summit, we thought today's topic, has a distinct relevance for different reasons. Amyloid angiopathy is relevant in Alzheimer's disease because it involves the accumulation of amyloid beta in the walls of brain blood vessels, contributing to brain damage, microbleeds, and worsening cognitive decline. It is often present alongside Alzheimer's pathology and may exacerbate its progression. Taking into account also the new molecules that are being approved all around the world, I'm sure you would agree with us on the importance of discussing this specific topic. So that's why I am delighted to introduce the chair of this session, a distinguished figure in the field of neurovascular research, Professor Joan Montaner, that I know him for many years now. When we were young, well, he was young, I was younger. Professor Montaner is the director of the stroke program at the Institute of Biomedicine in Seville and leads the neurology department at the Virgen Macarena University Hospital. Currently, he also coordinates the Neurovascular Research Lab at Valldabrand Research Institute in Barcelona, and his career includes over 300 peer-reviewed articles, groundbreaking research on stroke biomarkers, and innovative studies on brain ischemia. Dr. Montaner's expertise in biomarkers for stroke diagnosis and prognosis, and his leadership in therapeutic research make him great contributor to this field. So, Joan, please, could you moderate this meeting? Thank you.
Thanks, Xavier Montalban, for the nice introduction, and thanks to ACE Foundation for their continuous effort promoting research, clinical excellence, and training in Alzheimer's disease. And thanks for organizing this seminar, Cracking the Code of Cerebral Amyloid Angiopathy in Alzheimer. That I think it's really important and necessary, since the role of cerebral amyloid angiopathy and the bleeding risk associated to the emerging therapies in Alzheimer's disease are really hot topics nowadays. So I think it's the right moment to have this session, and we will have really excellent speakers like Dr. Fabrizio Piazza and Professor Zain Jaumoktane, really top scientists, I would say father and mother of the first ever description of inflammatory and iatrogenic forms of CAA, respectively. So great to have them here. I think most of you know what is this disease and how devastating it is. Cerebral amyloid angiopathy, it's so prevalent pathology, and it's strongly associated not only with Alzheimer's disease, but with aging itself. For me, in these last years, when we talk with colleagues in neurology, it's really interesting to see the different view that we have on the same disease, depending on what is our dedication in neurology. If we are in a memory clinic, we have a different view of patients with CAA. If we are in stroke unit and we have those patients due to large bleeding, sometimes we have a different view of that patient. And nowadays, it's really trending, the view that we have in clinical trials with anti-amyloid beta drugs, and when this area or microbleeds appear, again, a different view of the same disease. So it's a very polyedric disease, but I think we are biased depending on how the patient goes into the circuit. And in my opinion, that's something that is not good for the field. And I really think that we need to have a global view of CAA and an integrated view of all the actors that play a role in the management of this disease. We have, I mean, we are not starting with this. We have a lot done in the past years, and I think we really have a common language for getting this common view of CAA in the coming years. We have the renewed Boston criteria 2.0. We have very nice radiological classifications, taking into account also all the hallmarks of small vessel disease by Harimi-Du. We have the von Satter classification for pathology severity of the disease. So we have the pieces to talk a common language on CAA. However, there are lots of things that we don't know about CAA, and I think that our speakers will put some light on that. No, it's a vascular deposition in the blood vessels. Is happening sometimes 30 years before a patient comes for a bleeding, or we see an MRI full of microbleeds. So why is this happening? Why we have cases with or without intracerebral hemorrhages? Are just different phenotypes, or are we in front of different types of disease? That's something that we really need to learn in the coming years. We know that the severity of CAA is determined by vascular remodeling processes. We know that it's a very strong smooth muscle cell loss, blood-brain barrier leakage, and we have a lot of perivascular inflammation in the last stages of the disease. We are learning what's going on with the lymphatic and lymphatic system. We know that the deposition occurs in arteries, but not in veins, something really tricky. And we know that some risk factors, age, ApoE, genotype, or high von Satter CAA scores are predictors of having intracerebral hemorrhage in the future in these patients. So we are learning a lot also on prognostics. But I think it will be a revolution, or there are already a revolution with the new anti-amyloid drugs. And in the trials, we have seen these side effects related with microbleeds, area. And it's something that we really need to understand very well if we have to treat thousands of patients in the coming years, and to understand very well the mechanism of action of these drugs. To know if we really mobilize amyloid from the parenchyma to the vessels, and that's the reason of these bleedings. That's something that we all believe, and we are not fully sure. And I'm sure that our two speakers will really help us to understand much better these bleeding complications. I think that's going to be really great when we have an understanding of why these bleedings are happening, not only for Alzheimer's disease management with the new drugs, but also for CAA, for pure vascular CAA itself, because we have no therapy for this disease. It's really orphan. So we really need some type of drugs for this disease. I think something that will be very interesting in the coming years is how to design properly clinical trials when we have drugs that can mobilize amyloid from the vessels to the bloodstream, similar to what we are doing now with the monoclonal antibodies, cleaning, let's say, the amyloid from the parenchyma. If we have these drugs and we are testing some siRNAs in amyloid angiopathy, vascular amyloid angiopathy, there are some interesting Abeta 40 vaccines that are also decreasing the vascular load of the disease. So if we have these drug candidates in the future, it will be very interesting to learn how to design properly the trials. Do we target vascular cerebral amyloid angiopathy, or we combine in Alzheimer's disease with microbleeds, those therapies with the conventional antibodies against Abeta 42? That's going to be something really very interesting that we should think all together about. Not forgetting that vascular protection, both in Alzheimer, in CAA, it's critical, and to really control very strictly these vascular risk factors, it's really important. I think that among the unmet needs is also the issue of biomarkers, CSF or blood biomarkers. The revolution we have seen in Alzheimer's disease will probably happen also in CAA. But nowadays, really, what we know is that these Alzheimer's disease biomarkers, if we apply them in CAA, we are able to distinguish CAA from healthy controls, but not from Alzheimer's disease itself. So it's an overlap of CAA and Alzheimer's disease results when playing with these biomarkers in CSF. Let's see what happens when we use more plasma biomarkers. But that will be critical to have these markers and to know who will have these bleedings, because this could help a lot when we use Alzheimer's disease new therapies. So to help us to better understand all these complex issues on CAA, we have two top speakers. I will introduce the first of them. Dr. Fabrizio Piazza is a senior researcher at the University of Milano, Bicocca, where he got his degree in pharmaceutical biotechnology in 2008. And he did a postdoctoral fellowship at Tufts University in Boston. And since 2012, he's coordinating a huge international inflammatory CA-beta network focusing on biomarkers for inflammatory CAA and Alzheimer's disease. He published really key studies, annals neurology papers showing that during inflammatory episodes of CAA-related inflammation, the levels of anti-beta-amyloid antibodies raised a lot in CSF and were correlated with neurodegenerative markers. And he showed the diagnostic and predictive biomarkers for anti-amyloid therapies. And he did also a lot of work on definitions of ARIA and establishing the CAA-related inflammation as models for anti-beta treatments. He will show about that. He has a lot of prizes. I will not go into detail, and got of big grants that allow him to really do very interesting research in the field of CAA.
Good morning, everybody, and thank you, Joan and Fondazione Ace, for inviting me to speak today about the mechanistic insight into the anti-amyloid beta autoantibody-driven spectrum of CAA-related inflammation. And during my presentation, I would like to present to you the most recent information suggesting that ARIA adverse events in Alzheimer's disease immunotherapy may represent a iatrogenic manifestation of CAA-RI. So let's start with a brief history on the amyloid immunotherapy. As we know, beta amyloid can be produced and cleaved by a proteolytic cleavage pathway and form two different species of beta amyloid. The A beta 40, which is more soluble, and so is usually deposited on the vasculature, forming CAA, cerebral amyloid angiopathy, and A beta 42, which is very, very sticky, and so is quite very fast and immediately deposited into the brain parenchyma, forming the typical amyloid beta plaques, fibrillary beta amyloid plaques. The two amyloid and condition, they are present in a high comorbidity rate, in particular with the progression of the disease. So in the attempt to try to remove these presumably toxic deposits of beta amyloid, the field tried to stimulate the immune response, administering antibody or stimulating the production of antibody in order to remove these species. However, the very first trial was around 2002 with an active immunization, and this trial was quite short interrupted because the development of encephalitis following immunization, and these encephalitis were also severe in some cases, leading to the death of the treated patients. So we immediately pass through the passive immunotherapy with the attempt to better modulate the immune and inflammatory response consequent to these therapy. And different monoclonal antibody have been designed and tested in clinical trial over the different years. However, even in this case, these passive monoclonal antibody immunotherapy show immediately some unexpected MRI images alteration that were initially reported as white matter hyperintensity signal changes, but with the testing of several other antibodies, these undesired side effect of monoclonal antibody immunotherapy start to be consistently reported with all of them. And so the Alzheimer's Association in 2010 and 2011, in response to the guidance issued by the US FDA and the Alzheimer's Association, convened a roundtable, and the term vasogenic edema was further evolved in order to define two different subtypes of ARIA. ARIA E, which are white matter hyperintensity due to vasogenic edema, and ARIA H, often presenting in association with ARIA E, and related to the hemosiderin deposition. So what are these ARIA E on MRI? So are MRI entity, nothing related to clinical effect by the definition of these acronyms. And as you can see here, they are transient lesion and due to vasogenic edema, effusion, exudation of proteinaceous fluid, appearance on specific FLAIR images, on specific FLAIR sequences. while area H are permanent lesion and can be divided in different MRI markers on T2 stars or SVY, more sensitive SVY MRI sequences. However, we know that these MRI markers, and in particular the MRI markers used for area H, are hard to differentiate from sporadic CAA. In fact, these markers are also implemented in the Boston 2.0 criteria in order to make a diagnosis of CAA in clinical practice. And also, we know that area E in immunotherapy are also indistinguishable from the spontaneous area E developing in CAA-related inflammation. So what is a CAA-related inflammation? CAA-related inflammation was first described in 2004 from a retrospective evaluation of a cohort of 42 patients with a former and pathology-proven definite CAA diagnosis from the Boston group. And the reanalysis identified 7 cases which, of course, have CAA because they derive from this cohort of CAA-proven cases, but also have some atypical inflammatory presentation at the level of the affected vessels that is usually not recognized in sporadic CAA. But also these 7 cases, they also show some MRI feature that was resembling the first coming and reported area E in clinical trials with monoclonal antibody. So in this specific setting, the term CAA-RI was named to define a rare and aggressive inflammatory syndrome presenting in a subset of sporadic CAA patients. A few years after that, we were looking for a patient in our affiliated hospital, which was presenting a probable CAA. And so by looking at this image, we start thinking about the possible commonality between the same radiographic imaging presenting spontaneously in CAA and in amyloid trials. So we develop an ultrasensitive test in order to explore the hypothesis that a kind of raised production of spontaneous anti-A beta antibody can be represent the key player in the spontaneous area in CAA. And we were lucky to demonstrate that, in fact, during the acute phase of CRI, in a small case series of 12 patients, there is a 3 to 4 times increase of these spontaneous anti-amyloid autoantibody, which return to the same level of other group of controls that we use during the full remission, clinical and radiological remission of area E. And was also interesting to note that this increased amount of antibody, they were strongly correlated with the increased amount of soluble beta amyloid, both in the 40 and 42 form into the CSF. And so we start thinking and suggesting that the mechanism by which this antibody they works and they may cause ARIA E is due to the disassembly of the brain deposited beta amyloid, causing a burst, an overload of soluble species that can cause these imaging abnormalities. Also, we shown in a single case that after administration of 5 consecutive high-dose steroids, there was a very strong reduction of these spontaneous antibodies until returning to the same level after the remission of the disease. And this hypothesis was further reinforced with other study that we did in other cases, showing that there is a focal reduction of amyloid beta on PET near the radiographic area E appearance, as you can see here. And so we start thinking that area E may result from the time and concentration dependent antibody-mediated exaggerated clearance effect of these antibodies. And so, speculating to clinical trials, we start thinking that ARIA E reflect the proof of an exaggerated target engagement effectiveness in disentangling the fibrillary plaques in Alzheimer's disease. and start proposing CRI as a valid human spontaneous model of therapy-induced ARIA-E. So also these data were in parallel confirmed in clinical trials showing the same evidence that I show you in CRI. And so these attracted a lot of attention, and we decided to establish the ICAB International Network in order to collect as much as possible of these CAA-RI cases and start studying better biomarker and mechanism in CAA-RI. And in the subsequent year, we received a lot of cases, and we tested all of them, and we showed that these CRI can be found in different presentation, not only in CAA, pure CAA patient, but also in presymptomatic AD, Down syndrome-related AD, and very recently also coexisting in iatrogenic CAA and immediately after COVID-19 vaccination as an exacerbated immune and inflammatory response to the vaccine, probably. So all of these suggest that CRI may be an anti-A beta autoantibody-driven spectrum disorder that may occur along the AD continuum, encompassing the broad range of AB-associated conditions. With the continued receiving of and the increasing number of these cases, we were also able to publish this study on the natural history and treatment outcome of ARIA-E in the largest actually reported case series of CRI patients from the real clinical practice. And what that we were able to demonstrate is that, in fact, there is a lot of commonalities with ARIA in clinical trials. First of all, there is a backgrounding CAA in CAA-RI, and so CAA may represent, in fact, a risk factor for ARIA as demonstrated in clinical trials. But in these cases, there are no more very severe as originally reported, but with the increased education and the increased knowing that these CRI exist, more and more patients are reported with very minor or mild symptomatic presentation. And also, we were able to find that ApoE-epsilon-4 is potentially also a risk factor for CAA-RI, as 37% of patients, they are ApoE-epsilon-4, and that 36%, so more than 1/3 of CRI in our cohort, had a history of MCI or AD, which is a prevalence that were never reported before in the previous cases. Previous cases. So we were also able to suggest a protocol for ARIA-E treatment by proposing that 5 intravenous boluses should be used to treat this condition. And also to show that the maintenance of a very long tapering is important, because recurrence is more likely in the intravenous corticosteroid past therapy is suddenly stopped compared to long tapering of until the complete radiographic and clinical resolution of the ARIA on spontaneous ARIA on MRI. However, when we go to look for potential prognostic predictors, what that emerges is that none of the clinical and MRI baseline feature, including ApoE and CAA load on MRI marker, were significantly associated with prognosis. And so we think that the course and prognosis of ARIA-E is associated with the CSF concentration of anti-A-beta autoantibodies and the downstream immune-mediated reactivity that this antibody may induce. And to test this, we explore a longitudinal in vivo imaging marker, also complemented by a multimodal and multiparametric CSF testing, applying also all the gold standard state-of-the-art technologies and methods applied both in CRI clinical practice and in immunotherapy clinical trials. And what that we found is that during the acute presentation of CRI, in our cases, there is a confirmation of an increased concentration of anti-beta amyloid autoantibody, which decrease at 5 months post-treatment, redosing into the CSF, and after corticosteroid therapy. And was also very interesting to know that there was a specific spatial colocalization between microglia activation on PK1195 PET as a tracer and the radiographic appearance of area E on MRI. And that this colocalization, spatial colocalization, was specifically associated and restricted to patients with AD plus CAA comorbid disease, as you can see here, compared to almost non-colocalization in patients with CAA alone without AD, as defined in these cases by the negative ATN biomarker on the CSF. What also interesting to know that there was an evidence of increased CAA, so the reporting on new ARIA H or CAA, whatever you want, markers on MRI after the first occurrence of the ARIA E index event. And this is interesting because if we flash back to 2003, so more than 20 years ago with the first active immunization trial, we saw that it was already reported a shift in the relative distribution of beta amyloid 42 from plaques to CAA vascular deposition at different times after amyloid beta 42 active immunization. As you can see here, before immunization, there is almost no beta amyloid 42 in the vessels, while after active immunization start appearing some deposition of beta amyloid 42 into the vascular walls that increase at 20 months, but at 60 months post-immunization there is no more beta amyloid in the vasculature, so suggesting that this can be a kind of transient shift in the deposition. And also, there are not so much cases reported for passive immunotherapy, pathology on passive immunotherapy, but such as in this case, was also confirmed that there is microglia engagement in this case. This is a patient that has not just because ARIA, but was treated with aducanumab, and even in this case, has been shown a persistency of CAA on pathology. The disassembly of plaques achieved by monoclonal antibodies lead us to define the ARIA paradox, suggest the ARIA paradox model, suggesting that the disassembly of these plaques is causally linked to a paradoxical increase in CAA due to an exacerbated mobilization of beta amyloid, hyperperturbation, and neuroinflammation that can lead to first initial ARIA E appearance on MRI, and then culminate in the more severe CAA-related complications such as ARIA H. And all of these also fit with the risk factor that we found both in CAA-RI and AD, such as the antibody dose, which in a clinical trial, even if not yet tested, can be due to the sum of the monoclonal plus the autoantibody level and the dose frequency. And that this means that the high level of anti-beta amyloid spontaneous antibody at baseline may contribute in better define a safety therapeutic window to avoid the ARIA E occurrence. And the pre-existing CAA can constitute an effective risk factor because can serve as a scaffold to promote the rapid assembly and deposition of beta amyloid 42 generated from the disassembly of plaques, as also demonstrated in animal model in this work. So looking at all the evidence that I show you, we can say that the 2025 updated definition of CRI is defined as a subacute, potentially relapsing, corticosteroid responsive autoimmune encephalopathy within the AD and CAA spectrum continuum, characterized by raised CSF concentration of anti-beta amyloid autoantibodies. And these also lead us to reinforce our hypothesis that therapy-induced ARIA-E is in fact a iatrogenic CAA-RI manifestation. And the key open questions remaining are current monoclonal antibody removing A beta plaque at the expense of an increased CAA pathology? So in other words, we are curing AD, but we are accelerating CAA pathology in these patients. And so define if this is a transient or long-lasting effect should be very important, such as, and also will be important to consider potential preventive corticosteroid therapy in these patients, such as is in a certain way performed now with the new trontinemab antibody, the specific antibody in first phase 1 and in the next future phase 2 trials. And another consideration is that given many patients develop ARIA, could current trial efficacy be affected by and biased by the ARIA-related outcomes? So in other words, are we showing these positive effect, but can be more important if we reduce or avoid the ARIA incidence in these patients. And so personalized drug dose monitoring will be very important in order to maintain an optimal balance between the high dose efficacy in terms of Cmax and the reduced ARIA risk that has yet to be determined and implemented in the clinical use of these monoclonal antibodies. How to monitor CAA as a marker for the risk, so at the baseline for stratification and decision to start therapy or not in this patient will be is still very hard, and present these different challenges, and as was reported in these 3 cases, and this is in particular one very interesting case, very recent case study reported, where with the more sensitive 3 Tesla MRI, they shown that in a specific setting of CAA patient, the short-term 1-year follow-up monitoring for the lack of cerebral microbleeds and white matter progression can be used for reconsidering an initial diagnosis of CAA. However, these data cannot be very useful and translated in clinical trial for different reasons. The first one is the poor generalizability because the early stage and mild CAA in a clinical trial, as patients with less than 5 microbleed at baseline are usually excluded. And also because the Boston criteria 2.0, which were extremely well in a specific setting with acute, stroke presentation, so vascular presentation, are not so good to discriminate CAA, to diagnose CAA in patient without this presentation or with in AD clinical settings. And also this case that presented probably the appearance of this very mild CAA can take several years, potentially from 3 to 5 years to show progression of these MRI markers in AD patient. So biomarker of ARIA-E are becoming an emergent international priority, not only for a merely safety perspective, but also to better understand how and why the antibody works and to enhance safety and support clinical decision-making in the case that these ARIA events can occur, and potentially also to increase the generalizability to the broadened community of AD and CAA patients. So in this context, the testing for anti-beta autoantibody, we believe, may have all the requirements to be used as a companion diagnostic biomarker to assess risk stratification, drug tailoring, and dose monitoring in order to maintain this therapeutic window for safe and effective clearance of data in line with a precision medicine approach. To do this, we recently launched the ARIA-CRI-NET, Precision Medicine Advancement in ARIA Iatrogenic Spontaneous CA-related inflammation, in order to collect large case series and to validate not only the anti-A-beta autoantibody assay and testing, but also a plethora of other specific marker of neuroinflammation and vascular and complement activation, in order to explore the three main potential mechanisms as emerged by this study conducted by Roche with the image of gantenerumab study, and also the complement and the hemostasis component will be explored in our course. To do that, of course, it is very important to make collaboration and to work together in order to really make progresses. And so collaborative and interdisciplinary efforts such as the ICAB International and the recently launched ARIA-CRI-NET initiative will be very important to reach the aim, avoiding data fragmentation in small case series, and so having much great potential. So thank you everybody for listening to my presentation. I would like to thank also my collaborator and please contact us in case you would like to join the ARIA-CRI-NET study.
Our next speaker is Professor Sein Jaunmurtane, originally coming from Riga. She is now a consultant neuropathologist at Queen Square Institute of Neurology in London, and she's specialized in both intraoperative and postmortem diagnosis with a special dedication to prion diseases. Her major, let's say, scientific contribution to cerebral amyloid angiopathy lies in the first one to demonstrate the iatrogenic transmission of amyloid beta protein in humans. In fact, in 2015, she identified A-beta deposits in the brain of patients with Kersel-Jacob disease acquired through contaminated growth hormone. That was really a revolution, suggesting A-beta co-transmission with prions. And later, in 2018, she reported several cases where childhood neurosurgical procedures led to CAA and even intracerebral hemorrhage decades after that surgery. So in a way, she defined iatrogenic CAA as an emerging condition with early onset and symptoms such as brain hemorrhages. And in many countries, we are now describing many of these cases. So her work really transformed our way to understand the medical procedures and the vigilance of young patients with history of neurosurgery. A great contribution. So please, Sein, it's your turn for talking now.
Thank you, John, for the kind invite. And as mentioned, my name is Zana Jaunmurtane. I'm an academic neuropathologist working at UCL in London. And today I'm going to talk about the neuropathology of cerebral amyloid angiopathy and its comorbidity with Alzheimer's disease. So in CNS, there is a range of amyloidosis which can misfold and lead to a range of neurodegenerative diseases. Majority of them accumulate in neurons, and examples, or extracellular space, and examples are misfolded prime protein, misfolding of amyloid beta peptides, tau misfolding and aggregation either in neurons and or astrocytes, TDP43 misfolding and aggregation and accumulation in neurons or glial cells, or misfolding of alpha-synuclein, and depending on the conformation, aggregation either in Lewy bodies in neurons or glial cells. oligodendrocytes are also astrocytes. But when we talk about the cerebral amyloid angiopathy, there is a different range of proteinopathies which can lead to cerebral amyloid angiopathy. By far the most common is, of course, amyloid beta, which can accumulate in the blood vessels either due to sporadic, that is unknown reasons, or genetic mutations in APP presenilin 1 or presenilin 2. Prion, due to prion gene mutations, transthyretin, APRI, ADAN, cystatin C, and gelsolin. And from the diagnostic point of view, the way we diagnose cerebral amyloid angiopathy is at the very initial stage looking at the hematoxylin eosin staining, where we would see the abnormal discoloration and eosinophilic appearance of the blood vessels due to the amorphic amyloid deposition in the blood vessel walls. But of course, that's a very non-specific finding, and per se on its own doesn't confirm the presence of cerebral amyloid angiopathy. We can do a range of histochemical stains such as Congo red or thioflavin T or thioflavin S, where again we would see the binding to the amyloidogenic structure, and in that way confirm that indeed the eosinophilic amorphous material we saw on hematoxylin eosin stain sections indeed is amyloid. We can see that either as bright field or under polarized light for Congo red staining, where we see this classic apple green birefringence. But again, with this staining, all we can confirm that there is amyloid deposition in the vessel walls, but we cannot really define what type of amyloid has accumulated in the blood vessel walls. And for that, for routine purposes, we need immunohistochemistry or extract the protein for the blood vessels and confirm the type of the protein with mass spectrometry. And then using the specific antibodies, we can be very specific and define what type of protein or peptide has accumulated in the vessel wall and has led to the cerebral amyloid angiopathy. And in this talk, I will talk mainly about the cerebral amyloid beta angiopathy, which can be either sporadic, meaning we do not really know the exact causes why it has developed. It can be genetic, or importantly also to remember, it can be iatrogenic in its nature. And why specifically we're going to talk today about cerebral amyloid beta angiopathy is the fact that we can see it either as isolated cerebral amyloid angiopathy, where we do not see any concomitant pathology, but by far most importantly, why we really want to specifically talk today about cerebral amyloid beta angiopathy is because we commonly see it together with Alzheimer's disease neuropathological change. So the etiology of cerebral amyloid beta angiopathy is very much related to the cleavage of amyloid beta peptide from amyloid precursor protein. And then depending on the isoform which has been generated, it will have a propensity to either develop isolated cerebral amyloid angiopathy or Alzheimer's disease, where in cerebral amyloid angiopathy, the primary amyloid beta isoform typically is 1 to 40 in length, whilst in Alzheimer's disease in the brain parenchyma, it's typically a little bit longer peptide 1 to 42 in length. And equally, both in isolated cerebral amyloid angiopathy or in Alzheimer's disease together with CAA, we oftentimes see secondary or tertiary amyloid beta isoforms of various different lengths or different truncated species, that is different post-translational modification events. And the one length which most frequently accumulates in the blood vessel walls, the 140, tends to be more soluble than the 142, which accumulates in the brain parenchyma. And when we talk about the sporadic types of amyloid beta angiopathy, as I mentioned, there is a lot we still do not know why it develops in the first place, but we do know that there are some genetic risks which makes the patient more likely to develop sporadic CAA if they harbor the specific genetic alteration. And one of those very well-known established genetic risks for CAA, including Alzheimer's, in the spectrum of Alzheimer's disease, is amyloid is the ApoE4 and ApoE2 genotype. And the ApoE4 genotype instances, in those instances, it develops typically together with Alzheimer's disease, that the patient develops Alzheimer's disease, new pathological change, and also has cerebral amyloid angiopathy. And the ones with isolated predominant CAA show more frequently ApoE2 genotype population. And also paradoxically, whilst ApoE2 is a protective factor for Alzheimer's disease, when the patient goes on and develops cerebral amyloid angiopathy, this cerebral amyloid angiopathy, in contrast to the one which develops in Alzheimer's disease, tends to be with much more hemorrhagic complications from the CAA. And from the sort of classification point of view, the amyloid angiopathy, which is predominantly restricted to the larger caliber arterioles or also venules, we refer to as type 2. But when we see capillary involvement, which is typical signature for ApoE4 genotype specifically, we refer to as CAA type 1, indicating that it's with additional capillary involvement. So when we talk about the genetic causes of cerebral amyloid beta angiopathy, based on the mutation type in the amyloid precursor protein gene, the mutations segregate and the clinical symptoms very much segregate depending on the mutation type. So there are a range of mutations, typically around the 693, 694 region, which clinically predominantly present with cerebral amyloid angiopathy. Then there are a range of mutations where the patient shows a combination of Alzheimer's disease, new pathological change, and cerebral amyloid angiopathy. And there are other set of mutations where the predominant classic clinical presentation is that of Alzheimer's disease, but these patients also to some extent have cerebral amyloid angiopathy. And of course, other genetic pathogenic mutations known to cause Alzheimer's disease, such as presenilin 1, presenilin 2, APP gene duplication, or chromosome 21 trisomy, that is Down syndrome, also cause, in addition to Alzheimer's disease, new pathological change, to variable extent cerebral amyloid beta angiopathy. So when we talk about the iatrogenic cerebral amyloid angiopathy, which is arguably more recently understood and acknowledged possibility of the cerebral amyloid beta angiopathy development, the two classic scenarios how under certain circumstances the pathology can develop is either through medical treatments with cadaver-derived preparations such as growth hormone, or through surgical manipulations with contaminated instruments. And whilst initially it was very much considered that it's predominantly cerebral amyloid angiopathy what develops in these patients, increasingly we are recognizing that there is a significant Alzheimer's disease new pathological change present in these patients' brains as well. And just to very quickly remind about the timeline of our understanding of the role of amyloid beta for human iatrogenic transmission. So at experimental level, using APP23 transgenic mice, the fact that these mice can develop cerebral amyloid beta angiopathy or parenchymal deposition was demonstrated already over 10 years ago, where back in 2009, Matthias Jucker's team showed that either after injection of amyloid beta seeds or insertion of contaminated steel wires, these mice went on and developed amyloid beta pathology in their brains. And also the same team a little bit later demonstrated that after intraperitoneal inoculation with amyloid beta extracts, these mice developed specifically cerebral amyloid angiopathy after prolonged incubation times. So when we talk about the prion protein and iatrogenic prion disease, so what are the common known routes of iatrogenic prion disease and how they may or may not be relevant to cerebral amyloid angiopathy? So for prion disease, the established routes for iatrogenic transmission would be through corneal transplants, through insertion of contaminated EEG electrodes, through neurosurgery, through cadaver-derived growth hormone treatment or cadaver-derived dura mater grafting, or more recently through blood transfusion variant CJD. And in France and UK in particular, the growth hormone treatment prion diseases are by far the most common. And that's also the cohort in which we were able to first demonstrate the possibility of amyloid beta transmission, including cerebral amyloid angiopathy. So when looking at amyloid beta pathology in the cohort of patients with iatrogenic prion disease and comparing the extent of cerebral amyloid angiopathy and parenchymal amyloid beta pathology in these patients with a large range of sporadic prion disease cases and genetic inherited prion disease cases, we demonstrated that in half of these patients, there is substantial parenchymal amyloid beta pathology, so that is Alzheimer's type amyloid beta pathology, and on top of that, there is also substantial increase of vascular amyloid beta pathology, both in leptomeninges and cortex, which was not explainable by any pathogenic mutations or genetic risks, and also the age group of the patients was such that at that age range in the third and fourth decade, you would not expect to see cerebral amyloid angiopathy or parenchymal amyloid beta deposition as part of aging. And with this, we proposed that at the time when these cadaver-derived growth hormone preparations were made, so when from cadavers, the growth hormones were extracted, pituitary glands were taken and growth hormones extracted, that they must have contained not only prion seeds, but also amyloid beta seeds, which then after crude homogenization and injection as growth hormone treatments led to the development not only of prion disease, but also iatrogenic amyloid beta pathology, including cerebral amyloid beta angiopathy. Soon after, similar scenario was demonstrated in 5 patients who had received cadaver-derived dural grafting. And in these patients, specifically, the dominant pathology was cerebral amyloid beta angiopathy. And as you can see in this timeline for these 5 patients, the other 2 patients who didn't have amyloid beta pathology, they are with the shortest incubation periods, really suggesting the role of the incubation period and the time after the occurrence for the amyloid beta pathology, including cerebral amyloid beta pathology, to develop. Since then, it's been also demonstrated at experimental level using transgenic mice that these mice go on and develop cerebral amyloid beta angiopathy and parenchymal deposition after injection of cadaver human growth hormone material extracted exactly from the same vials which were used for the treatment purposes back in 1970s and 1980s, really confirming also at experimental level what we saw in human observational studies, that these pituitary glands which were extracted from cadavers, they really contain not only prion disease, but also amyloid beta seeds, which then after prolonged incubation periods have led to development either to prion disease only, prion disease with amyloid beta, including cerebral amyloid beta angiopathy, or isolated amyloid beta pathology. And this really led us to thinking whether other known routes of prion disease transmission, such as through neurosurgical instruments, could also play a role for amyloid beta transmission in humans, that not only growth hormone and dural graft cadaver-derived medical treatments led to amyloid beta pathology development, but could the other routes be as influential and relevant as well? And to address this, we looked at our neurosurgical biopsy cohort, specifically for patients who were diagnosed on their brain biopsies with cerebral amyloid beta angiopathy. And we specifically focused on patients who were young in their ages, in their 3rd or 4th or maximum 5th decades, to really enable us to segregate a possibility from of sporadic cerebral amyloid angiopathy from potential iatrogenic transmission cases. And we were able to identify 3 such cases where we also had the clinical information available. And what we can see in these patients, which are shown in these snapshots here, that they all 3 had indeed widespread leptomeningeal and parenchymal cerebral amyloid angiopathy. Some of them also had capillary involvement by amyloid beta. Some of them had parenchymal deposits freely in the neuropil, shown there with the red arrows, and capillaries with the blue arrows. During looking at these brain biopsy cases, we also came across an autopsy where the patient had died of a devastatingly large intracerebral hemorrhage. And what we found on autopsy, that this patient also had very widespread leptomeningeal and parenchymal cerebral amyloid angiopathy, plus the parenchymal pathology reached the maximum tau phase 5. And when looking at these patients, we observed the following. So they all underwent brain biopsies, or one of them unfortunately died due to large intracerebral hemorrhages. And when looking at their past medical history, it turned out that they all had undergone childhood neurosurgeries for various reasons and in various countries. And only one of them, there was also an absolute definite evidence that there was no treatment with dural grafting performed during the neurosurgery. And for the other 3, there was no indication that the cadaver-derived dural grafting would have been used. They were a mixture of APOE4 genotypes, so there was some genetic risk for these patients to develop amyloid beta pathology, but also that would be very unusual for the age they had developed cerebral amyloid beta angiopathy, but none of them had any pathogenic mutations, which could explain the early onset of amyloid beta in parenchymal pathology and amyloid beta cerebral amyloid angiopathy. And then, to our surprise, going through the published case reports in the literature, we came across 4 further patients with identical clinical history. Brain biopsies due to large intracerebral hemorrhages at young ages, pathologically confirmed cerebral amyloid beta angiopathy, and neurosurgery for various reasons at young age. Subsequently, there have been published more cases of exactly the same story, and currently there are only 2 case reports in the literature where the patients have young onset cerebral amyloid beta angiopathy, but no evidence of childhood neurosurgery or any other treatment which would explain iatrogenic transmission. But all the other cases, as I'm showing here, there is a clear evidence of iatrogenic transmission of amyloid beta, resulting in fatal and devastating intracerebral bleeds under certain circumstances. And since then, as I mentioned before, there are over 100 cases, 100 patients published who have developed cerebral amyloid beta angiopathy and devastating intracerebral bleeds, either together with prion disease due to cadaver-derived growth hormone treatment, without prion disease as a pure amyloid beta cerebral amyloid angiopathy, due to cadaver-derived growth hormone treatment, the same for cadaver-derived dural grafting, either together with prion disease or without prion disease, or through contaminated neurosurgical instruments. Very importantly, it's important for me to note that in past, before it was banned, cadaver-derived dural grafting was used not only for brain surgeries as a patching material, it was used for a range of manipulations, range of neurosurgery spanning from gynecological to thoracic to various different surgeries. And since then, there have been also case reports published where patients have developed cerebral amyloid beta angiopathy due to embolization of hemangioma in the neck with dural grafting, or due to cadaver-derived dural grafting for cardiac surgery. They have, after prolonged incubation periods, developed intracerebral bleeds due to pathologically confirmed cerebral amyloid beta angiopathy. And this really highlights that under certain conditions, through certain routes, such as contaminated neurosurgical instruments or cadaver-derived dural matter grafting on growth hormone treatment, not only prion protein is transmissible in humans, but also amyloid beta is transmissible. It results to parenchymal amyloid beta deposition of Alzheimer's type, but also cerebral amyloid beta angiopathy, which then leads to devastating, including fatal consequences, such as large intracerebral bleeds. And this leads me back to the etiology of cerebral amyloid beta angiopathy and associated complications. Before we talk about the complications, to really understand the mechanism of the complication better, what are the typical affected anatomical regions by cerebral amyloid beta angiopathy? So typically the affected blood vessels will be either in cerebral or cerebellar leptomeninges and gray matter. And the other area where these amyloid beta deposits can develop in the vessel walls, in particularly in very advanced cases where there is already very widespread leptomeningeal and gray matter pathology in cortex or cerebellum, are the deep gray nuclei. And in the cerebral cortex, the amyloid beta angiopathy, in particularly in the leptomeningeal compartment, but also in the cerebral cortex itself, shows this predilection to the occipital lobe, which might be to do with the mechanistic clearing of amyloid beta during night, but for that the experimental evidence is lacking. But definitely from the new pathology point of view, we do see this predilection for cerebral amyloid beta angiopathy, in particular in the occipital lobes. And as I mentioned before, cerebellar amyloid angiopathy is also very commonly seen, and the deep gray nuclei involvement is seen when we see very advanced cortical cerebral and cortical cerebellar amyloid angiopathy. In terms of where exactly amyloid beta deposits in the vessel walls, so typically those are arterioles, but it's also important to remember that they can be capillaries, in particularly in ApoE4 genotype cases, but also importantly to remember that the amyloid beta can deposit in venules as well, not only in the arterioles or capillaries. And in terms of the way of this grading, how we use the grading systems to determine from the pathology point of view the severity of amyloid angiopathy, there are two commonly used grading or staging schemes. The oldest and most established is von Sattel grade, which assesses the load of amyloid beta in a single vessel, as shown in this schematic here, where if the vessel only is partially involved by amyloid beta deposition, it's grade 1. If it's circumferentially involved, it's grade 2. If the vessel already starts to show an obvious dysfunction with the wall splitting, it's the stage 3. And when it's already amyloid beta completely obliterating the vessel wall, that's the most advanced stage or grade or phase 4. More recently, Professor Seth Love has developed a further expansion and further sort of grading scheme for amyloid beta angiopathy assessment, which not only looks at individual involvement of a blood vessel by amyloid beta pathology, but it looks specifically also to the extent of amyloid beta angiopathy across the brain, which von Sattel grading is not really addressing. In the Love criteria, there is also a specific notion of the presence or absence of capillary involvement, and also notion whether the blood vessel shows evidence of damage or not, such as thrombosis by the amyloid beta, fibrinoid necrosis, wall splitting, or a complication in the form of microhemorrhage. So what Love criteria provides is more sort of an overarching wide characterization of amyloid beta pathology in the vessel, not only in an individual vessel wall, but across the brain, by looking at this extent of amyloid beta angiopathy, presence or absence of capillary involvement, and evidence of single vessel damage across all the assessed areas. So on that note, I would like to also very briefly to address how these previous von Sattel and Love criteria staging schemes very much differ from the amyloid beta staging scheme in Alzheimer's disease, that is tau phases. So what tau phases assess is the topographical, that is regional distribution of parenchymal amyloid beta angiopathy, parenchymal amyloid beta pathology, whereby in the tau phase 1, we see deposits somewhere in the neocortical regions. They can be quite randomly distributed. When amyloid beta parenchymal pathology progresses, it starts to involve the limbic regions, and that corresponds to tau phase 2. Then it progresses further to the deep brain nuclei, tau phase 3, progresses further to the midbrain structure, specifically substantia nigra, that is tau phase 4. And finally, in the most advanced stages, parenchymal amyloid beta pathology reaches cerebellum, and that corresponds to tau phase 5. And here, importantly, what is included in the tau phases are the parenchymal deposits, either diffuse deposits, diffuse plaques, or the plaques with central amyloid cores. But what is not included in the tau phases is any kind of vascular amyloid beta angiopathy, either cortical parenchymal or leptomeningeal. So that's a very important distinction, therefore, that in Alzheimer's type tau phase pathology staging, we are specifically looking at the neuropil pathology, and we are not looking at the vascular pathology. And for the assessment of the vascular pathology, that's why we need to use either von Sattel grading or Love criteria, which enables this more extensive assessment of amyloid beta angiopathy across the brain. So now the complications of the cerebral amyloid angiopathy, why cerebral amyloid angiopathy is such an important thing to study. So the complications of cerebral amyloid angiopathy due to the fragility of the vessel because of the amyloid beta wall blockage are hemorrhages and microbleeds. The hemorrhages can be large, devastating intracerebral or subarachnoid, but they also can be as multiple small tiny dots resulting in microbleeds. It's important to also note that cerebral amyloid angiopathy can also result in ischemic infarcts or microinfarcts, not necessarily accompanied by hemorrhagic events. And importantly, as will be addressed in the other talk, amyloid beta angiopathy amyloid beta itself can induce inflammatory reaction, which can be either perivascular, lymphocytic, or histiocytic, and we refer to as cerebral amyloid angiopathy related inflammation, or it can result in a full-blown active wall destruction in vasculitic pattern, what we call as amyloid beta related angiopathy. And all this dysfunction inevitably consistently releases some blood cells, even if it's not associated with microbleeds or hemorrhage, which eventually results in superficial siderosis. And there is no surprise that therefore patients with cerebral amyloid angiopathy can develop cognitive impairment, either due to the associated complications such as hemorrhage or infarcts or inflammation, or due to the dysfunction of the blood vessels themselves. And cerebrovascular disease and cognitive impairment and its role, cerebral amyloid angiopathy role in it is quite well established. It is well established that if the patient has only cerebral amyloid angiopathy and no infarcts or hypertension-related small vessel disease, they are still at low likelihood of developing cognitive impairment. So the likelihood is low, but it's still there. If a patient, in addition to cerebral amyloid angiopathy, also has arteriosclerosis, so that's, for example, hypertension or diabetes associated small vessel disease, that increases the likelihood to moderate. And if the patient also has infarcts, in particularly around the occipital lobe with the small vessel disease presence, then the likelihood of developing cognitive impairment in this patient population is particularly high, really highlighting the importance how cerebral amyloid angiopathy can lead to cognitive impairment together with concomitant ischemic pathologies. So to summarize, cerebral amyloid angiopathy is common in aging and as part of Alzheimer's disease. The origins are diverse. They can be sporadic, genetic, iatrogenic. Clinical relevance is due to a variety of complications such as hemorrhage, vasculitis, cognitive impairment. Known genetic risks and pathogenic mutations or iatrogenic causes are known, but larger proportion of cases are unexplained. And differences in amyloid beta isoforms or conformations or amyloid beta species could contribute to the heterogeneity of clinical phenotypes and disease-associated complications. And on this note, I'll stop there and I'll pass it back to John. Thank you for listening.
So really nice talks. Thanks a lot, Fabrizio and Zane. Very, very interesting. I learned a lot of things. Thank you very much. I think now we have time for questions and to talk about some doubts in the field after your presentation. So we open the platform to the audience. Xavier and myself will also make some questions to you. So I will check if we already have some questions from the audience. It's not the case. So I might start. Fabrizio, you were talking a lot about the shift from of amyloid from the parenchyma to the vessel. I think this is the way we are trying to explain to everybody out of the field how the anti-A beta drugs are working. I know it's simplistic, but it seems very useful to explain what's going on. It's okay that we explain it like that, or is too simplistic and you would recommend to elaborate a little bit more how the drugs are working and the side effects of the drugs because of this shift to the vessel? What's your opinion?
Thank you, Joan and Xavier, again for the invitation. This is a very good question, and I would say that the real mechanism of action of this monoclonal antibody is far to be elucidated yet. So there was three main different hypotheses. The first one is the disassembly of plaques because of this antibody, but of course the antibody is not has not an enzymatic activity. So it means that the antibody can bind to the plaque and eventually can disaggregate because of the binding. Or the second hypothesis is that they can call for microglia, which is considered the main scavenger for removing these plaques together with the microglia and astroglia axis. And the third hypothesis was the so-called sync hypothesis. So we don't need to cross the BBB for this antibody to enter the brain, because if we bind beta amyloid from the blood, we can eliminate the beta amyloid from the brain parenchyma, because we are calling it like a sync effect that takes the name. I think that based on the previous trial results, the sync hypothesis is the less likely, because these antibodies such as solanezumab that were not crossing the BBB, so they were pushing the sync hypothesis model, they were unable to show any removal of plaques after treatment. But at the same time, solanezumab or these other antibody not directly binding to the plaques, to the fibrillar form of the beta amyloid, these antibody, they were also not showing any kind of ARIA. So if you don't remove the plaques, you don't have any ARIA, it seems. But if you target the plaques and fibrillary beta amyloid, such as lecanemab and donanemab, the two actually approved antibody in the US and in Europe, we are still waiting for donanemab. This antibody, they work very well in removing the plaques, as shown by amyloid PET, but the rate of ARIA is still not negligible. It seems, even if we cannot directly compare the rate of ARIA in the two trials, because the different safety plan monitoring by MRI, because there is a kind of shift between the two monitoring plans. And we know that ARIA is transient. So if you have less MRI or more diluted, you can see less rate of ARIA, in my opinion. So we cannot make direct comparison, but it seems that the dose and the time is very important and is related to the removal. And also for donanemab, as it has been recently shown that if you make the titration plan, such as the first one tested with the Biogen antibody, you basically have, you can cut by 1/2 the rate of ARIA, making very similar to lecanemab actually.
Okay, thanks a lot. Following these questions, I mean, when ARIA hemorrhage happen, do you need to have damaged vessels? I mean, do you need to have previous CAA there? That's why we don't include patients with more microbleeds, or even in front of clean vessels, let's say, we still can have this ARIA age.
So I think that making better diagnosis of CAA in AD is very complicated actually by actual techniques, because the MRI is not sensitive enough and also is not specific for imaging. Beta amyloid is only able to image iron, basically the T2 star as Y sequences. So it's a surrogate marker, which works extremely well in Boston point 2 in a stroke clinical setting, but in the AD clinical setting will be much harder, I think, particularly in the patient that will be treated in anti-amyloid immunotherapy, because we tend to treat patients very early in the prodromal stage when the MRI is not able to see any CAA. And on the other part, amyloid PET, in contrast to what we were thinking a few years ago, has been shown that it's not able to image beta amyloid deposited into the vasculature. It's not able to see CAA. So the amyloid PET is only able to image plaques, parenchymal plaques. And so if these trials shown a complete removal of plaques, doesn't mean that there is no CAA in our patient, as the presentation by the pathological point of view has clearly demonstrated and shown by Zane.
Thanks. So Zane, going to this pathological part, lovely talk. Thanks a lot. Nowadays, it's a lot of it's in fashion, this issue about the lymphatic system and the lymphatic system, and this issue that we have more amyloid deposition in the arteries but not in the veins. What's your opinion on the involvement in the disease of this lymphatic system? And you, at the end of your talk, you were talking just a curiosity on the superficial siderosis, and I have listened some discrepancies between colleagues trying to define where exactly this superficial siderosis is happening, if you know more about that.
Yeah, thank you very much. So obviously that's a very excellent question about the lymphatic system, very topical nowadays. I think on that note, it's important to remember that from the pathology point of view, we do see cerebral amyloid beta angiopathy not affecting only arterioles, but also capillaries and also venules, in particularly in advanced stages. And I think what we do see, why therefore somebody can question, oh, but how the lymphatic system really fit into that? Is it really draining along the arterial pathway, or is it really draining along the perivenular pathway? And if you see in both, how is that possible? But I think we do need to remember that amyloid beta is cleared normally through the CSF and through also the venous system. So I do think the reason why in advanced stages we see both arterial and venular involvement is the fact that there is a circulation of amyloid beta and re-entry through the CSF, through the blood, back in the brain. So therefore, through the periarterial drainage, as through the lymphatic pathways, we see it initially in arterioles, but then through the re-entry back into the brain, we also can see in the walls of the venules, explaining that actually the lymphatic system exists, and the presence of amyloid beta in the vascular wall, not only in arterioles but only venules, is completely reasonable. There is a completely reasonable scientific explanation for that. And in terms of the superficial siderosis, that's another obviously important question, which we still do not know much about exactly from the mechanism point of view, how it develops. And I do believe that there is a possibility that with the superficial siderosis, we see two types of hemosiderin deposition. One is, which is indeed coming through the red blood vessels due to the leakage of the blood vessels damaged by the amyloid beta in their walls. And that's kind of the most widely accepted mechanism how the superficial hemosiderosis develops. And we do see in typical sort of subpial perivascular compartments, which would explain this sort of perivascular leakage. But I do think we also need to remember another potential route of the hemosiderin presence in the parenchyma is that there is inevitably, because of the cerebral amyloid beta angiopathy, there is a very prominent reactive astrogliosis. And we do know that astrocytes also contain substantial amounts of ferritin, which can be released in the process. And I do think that there could be a combination where the siderosis is really coming from. One is through the leakage, but the other is actually released by the glial cells, parenchymal cells in the brain parenchyma itself.
Very interesting. You showed us the classifications from Sattel, Love, the topographical one. My feeling was that Fabrizio was saying that Boston criteria perhaps is not explaining everything if you think in both AD, vascular. What's your feeling? I mean, these classifications you showed us together with the Boston 2.0, are those enough? Would you like to have another one? Should we combine them?
Yeah, so I think that's exactly what Seth Love, when he implemented his criteria, his team's criteria, really attempted, because von Sattel obviously has provided a huge advancement in the grading of cerebral amyloid beta angiopathy. But we already for many years realized that that's not enough, because that's only assessing the blood vessel at a sort of a single level, and it's not really providing an information on the extent of the pathology. And that's what Love criteria really has attempted to address, that it's also providing this information on the extent of the pathology, in addition to the complications, the vasculopathic changes in the vessel wall itself. Of course, I think the Love criteria has really addressed that main problem, that addressing the extent and the severity of the vascular pathology. I think currently what is more required, rather than revising further the classification of the cerebral amyloid beta angiopathy, is actually making sure that across the centers, across the research centers and diagnostic centers, everyone is actually using the same classification. Because what's happening right now, there are centers who are still using von Sattel and centers who are using Love, but they all end up in numbers. And therefore, it's actually, when you see a pathology report and the classification system hasn't been mentioned, you actually don't know whether it's von Sattel 3, which doesn't give you the information on the extent, or it's score 3 according to Love criteria, which gives you an extent and actually is therefore providing completely different information.
I fully agree. Fabrizio, you were talking a lot about different drugs, different safety profile of those drugs. Do you think we should go to the safest one, or should we personalize the treatment and to look for profiles of AD patients with a very low risk of bleedings? How would the field evolve in that sense?
Yeah, I think that what we really need is to make very clear the terminology, because as we learned today, we are increasing a lot the number of these acronyms and making sometimes confusion. So in my opinion, we also need to rethink. We really need to talk about area H, or we can instead use CAA markers, because they are, I would say, exactly the same, even if not properly the same, because there is a very clear definition for the markers in CAA diagnosis, such as strictly lobar hemorrhages, blah, 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 blah. In area H is not so well defined in the original paper. The same is for area E, because area E, or white matter hyperintensities, which is asymmetric or monolateral in CAA-RI instead of clinical trial. So why don't talk about CAA-RI, in my opinion, in the future? Of course, there is need for more data and replication, but I think we are very close to properly think about that. And The other story is that we clearly need additional biomarker because the MRI we cannot ask too much to the MRI because can never be predictable. The MRI is only able to see something that already happened, and we need prediction biomarker. And of course, this fluid biomarker can be a fluid biomarker, hopefully in the plasma in the next future. And we need both biomarker for stratification, but also biomarker to monitor the treatment response in the unlikely event of an ARIA. So I think we can also think about corticosteroid treatment in ARIA. But the next question is, okay, when I have to stop treatment? Because this is the question that we usually receive from a neurologist when they send us the cases for antibody testing. So, okay, you test the antibody, they are very high, so I'm more confident in my diagnosis of CRI when I have to stop corticosteroids. So we need to define proper cutoff to follow and see if the biological response is completely, suppressed, and so say, okay, you can stop it. And I find also very interesting what I learned from the ADPD last month. Was very preliminary. We have to wait for more, with the full data that the trontinemab trial, they are now administering pre-treatment with corticosteroids, 10 milligram single injection before each dose administration. The reason is in order to reduce the site injection reaction. But I also think that this is very similar to the maintenance dose with CRI. So can this explain why in trontinemab we have so low rate of ARIA-E compared to all the other antibodies? This is a very interesting story that let's wait for the full data, but will be very intriguing to see.
Joan, are you here? Okay. Let me just thank you, thank Patrizio and Jana for your wonderful presentations. I have a couple of questions while we wait for Joan coming up again. So I think I saw in one of your slides, Patrizio, that the anti-TREM2 trial had in fact a higher percentage of ARIA in comparison to the anti-beta amyloid trials. I was very surprised for that because what the TREM2 is doing is modulating the microglia, right? And so do you have a clear explanation for that?
Yeah, I was surprised as you because honestly, I was really, interested in see the first results. And I was thinking that, okay, we don't need to target beta amyloid. We can just increase the activity of microglia and we can remove plaques maybe better than with the monoclonal antibody against beta amyloid. But instead of that, the results show that there is no or very few removal of plaques, but a massive increase in ARIA events. I would say much more than with monoclonal antibody targeting beta amyloid.
Right.
So, but this suggests that potentially the microglia activation is not the main mechanism of action in the removal of plaques, but that this is the main actor involved in ARIA.
Right.
That's a great information. So they have a dual role, positive.
Do you expect that the new monoclonal antibodies, the TREM2, will work differently and will have less percentage of ARIAs? What do you think? There is an Novartis trial now, right, coming up in Alzheimer's, and so what do you think?
I hope so. I don't have data, so I cannot comment more. But I think that potentially, if we were able to modulate the inflammatory response, neuroinflammatory response, potentially we can have the positive effect of inflammation without incurring in the negative effect of inflammation, exacerbated inflammation. Of course, I think that everything is related to the level of this antibody and the specific target that we need.
Exactly. I took advantage, Joanna, that you disappeared for a while. So let me just ask a second question, very, very naive question, coming from the MS world, right? So when we see this sort of inflammatory activity in area E, have you attempted to use a rituximab, just small doses of rituximab, well in advance of starting monoclonal antibodies, anti-beta amyloid therapy? Is there any experience of that? Joan, Zan, or Fabrizio, any of you?
I think that's has not been tested, but I mean, Fabrizio probably knows much than me on that issue, or if there is any trials ongoing for that. But in a way, it reminds a little bit this simpler strategy that Fabrizio was talking about, giving corticoids before each dose of the antibodies.
Right.
I don't think that never been tested before, and even the recommendation to use steroids during clinical trial was not, so clearly stated in the label.
Right. Thank you. Thank you.
Sane, a personal question. What was the feeling of yourself and the group when you described these iatrogenic cases?
Yeah, no, I mean, obviously, I think it depends on my feelings were very different from my senior colleague feelings at the time. I do think I was very naive and very young, obviously, at the time when I made the discovery. And obviously, I not necessarily at that time really appreciated the depth of the discovery. For me, it was yeah, it was exciting, but I don't necessarily at that time really appreciated the depth. Yeah, that's I think all I can say.
And I mean, now we are discovering cases in many different countries. It's really something that it's so serious. But I think we are still being very reactive, doing registries and so on. But are you aware of initiatives being more proactive? I mean, can we monitor patients that got that surgery? Can we anticipate that even with the biomarkers? Can do something before and not just waiting for big bleeding and then saying, okay, another case of iatrogenic CAA?
Yeah, that's the very important thing is that it's quite there are attempts making these initiatives for sort of international consortiums for monitoring. There are difficulties around that for that to happen. But I think on that note, it's really important also, and this is the right forum really to remind and advise that at the individual level as a clinician, it's really important to get this clinical history and ask and inquire about these about potential past medical histories, which not necessarily need to be restricted to cadaver-derived neurosurgeries. I think that's really important to really remind that every clinician should inquire about these histories, whatever the age of the patient is when they develop intracerebral bleeds or any other clinical evidence of cerebral amyloid angiopathy, because that is what we have found being a problem, in particular also looking at the very old clinical histories, but also even more recent histories, that there is simply no documentation whatsoever. And I think that's an important thing, as if there is one message from me to clinical colleagues is to inquire very actively and proactively from the patients, from the family members about any potential related treatments or medical interventions in past which might be of relevance.
Okay.
May I ask you a question, because I was also interested in your presentation on iatrogenic CAA. If I well understand, you said that patients with iatrogenic CAA, they have a very high percent comorbidity with AD. So usually the patient that you see on pathology, they both have CAA plus AD, right?
Yeah, so let me clarify on that. So there has been a little bit of already a misconception in literature that when we refer to iatrogenic amyloid beta transmission, that we refer only to cerebral amyloid beta angiopathy. So that's not the case. So pretty much every single patient I've seen, and I've seen a lot of them, they have very established amyloid beta angiopathy, but they also have parenchymal amyloid beta pathology of Alzheimer's type. Majority of them don't have the associated hyperphosphorylated tau pathology, which is a requirement for Alzheimer's disease neuropathological change. Having said that, increasingly, we already have reported a number of cases. Increasingly, we also are seeing in patients with particularly long incubation periods that there is also accompanying phosphorylated tau pathology of Alzheimer's type, really pathologically showing that the iatrogenic amyloid beta pathology can lead to established Alzheimer's disease, for which you require phosphorylated tau pathology presence. So from pathology point of view, there is always cerebral amyloid angiopathy, but there is also parenchymal amyloid beta pathology, but there not always is hyperphosphorylated tau neurofibrillary tangle pathology in majority of the cases. That's one thing to note, and there was something else I wanted to say on that note, which will come to me.
That's interesting, because in the last few months, through the RACRI net, it came that at least 2-3 cases where we found CAA-RI, so young onset CAA, completely unaware about the iatrogenic CAA. But then, incidentally, by looking at the medical history, we discovered that they were both responding to the iatrogenic CAA criteria. And so this is interesting, because in our CAA-RI, we always seen, or in the vast majority, we seen that you need to have both CAA and AD. And now you confirm me that also in iatrogenic CAA, you have both CAA and AD. And we found patients with CAA-RI. So I think it's interesting also because open the question to treat with steroids, potentially also iatrogenic CAA, in order to maintain the low level of immune reaction.
Yeah. One thing what I also did want to mention, because that's a question I often receive, whether from pathology point of view, we see anything pathologically different in these iatrogenic cases, either in terms of parenchymal amyloid beta, Alzheimer's type pathology, or neurofibrillary tangle pathology, or in terms of the cerebral amyloid beta angiopathy. And I must say, as hard as we have tried to see any differences from sporadic cases, we can't. And I think that's, again, is very important issue why the information on the past medical history is so crucial, because currently from the routine diagnostic pathology point of view, you cannot really separate them out. It also, in the original prion disease cohort, when we made the seminal discovery, it was really the age of the patients which stood out, not the fact that they had unusual amyloid beta pathology. It was really the fact that they were young people in their third decade, fourth decade. That was the thing which really stood out. This just doesn't make sense. How come they have no pathogenic mutations and they have this very advanced amyloid beta cerebral angiopathy and parenchymal pathology? So yeah, there's no obvious distinctive feature how to separate. Some people do suggest who have seen more of the cadaver-derived graft CAA cases, that those patients tend to have more sort of selected CAA with less of a parenchymal pathology, and that it can tend to aggregate around the dural graft patching. But in other cases where it's more of a systemic treatment, as for example, due to growth hormone treatment, we don't really see any distinctive patterns.
Yeah, that's interesting. If you have some cases with parallel CSF or a plasma, let's talk about that, because we need to replicate in big numbers the increased level of antibody that we specifically found in these iatrogenic cases. Thank you.
Zane, on something that we are worried about as neurologists, in the past, for organ transplants, we were taking more patients with traumatic brain injury, young patients, but now the main type of patient is older patients, intracerebral hemorrhage, and many of those probably have a CAA behind that hemorrhage in those cases that we use for organ transplantation. So do you have any thoughts on this? Do you think that it's true that they are old and perhaps it's not time to develop these type of things, but
Yeah, that's again is a very, very important question. I do think obviously nobody undergoes organ transplantation for no real reason, and I think when it comes to really sort of life and death situations, then it does take a long time for amyloid beta pathology to develop, and if they won't receive that organ transplant, then they will definitely not reach the time to develop the amyloid beta pathology. So it obviously is ethically very complicated question, but yeah, I think we do need to also be sensible that and give the opportunity to patients to benefit from organ transplants, but equally also doing everything was possible in terms of the improving the decontamination methods, single usage of instruments, working on improving that aspect, which has been really the main reason for the amyloid beta transmission or prion disease transmission to occur in the first place, rather than organ transplantation or blood transfusions for that matter. Also, again, working more and having safety procedures in place that the blood transfusions are checked and clean from infectious agents, rather than not collecting those blood transfusions or giving patients.
Yeah, right. And Fabrizio, you have been talking a lot about biomarkers. Xavier is also an expert on biomarkers to guide other neurological and neurodegenerative diseases. Now we are very close to have phospho-tau 217 out, and even people testing when they want, I would say. How can you imagine that the use of that blood easy to do biomarker will change what we are talking about? If complications of the anti-amyloid drugs, or how would this change the field? If you can hypothesize?
Yeah, again, when you talk about a biomarker, you need to clearly focus on the intention of use of that biomarker. So I think that all of these biomarkers would be very important if validated properly and confirmed in the next future for making stratification of patients. So select the right patients based on amyloid positivity instead of imaging, which is much more expensive and not broadly available. So will be good. But I don't really think that any of these biomarkers will be able to diagnose or predict ARIA, at least based on the results that we are preliminary finding in our courts. I don't think that any of these biomarkers, and I'm talking about the A-beta 40, 42, tau, any form of tau, or even NFL, they are not, predictable for ARIA. And what we need is to predict ARIA, because ApoE is, or the number of microbleeds, it seems to be a risk factor, but ApoE epsilon 4 is a risk factor. So it doesn't mean that if you're not ApoE epsilon 4, you cannot have any ARIA. Or the other side is, I think, is not fair to don't treat any ApoE epsilon 4 carriers, which is the one that likely need more for this treatment. So we need to find something to better, predict, and so avoid the occurrence of this ARIA. And in the worst case scenario, if some ARIA can occur, how to manage and early detect and properly therapeutically manage the unlikely events. So this is, we need to better, and every time focus on the intention of use and different biomarker. I don't think that one single biomarker will be, the only one.
Okay.
Yeah, we need to combine probably more than one.
Also, from a therapeutic point of view, I know you have been working, because we're together in some panels talking about trying to target not only A-beta 42, but A-beta 40 vaccines, for example. if they result to be really effective and we are able to mobilize A-beta 40 from the vessels, how would you like to use those type of drugs or strategies?
Yeah, combination therapy, I think, will be also another very interesting, strategy to test in the very next future, because it's so complicated, both the disease process and the action of this antibody, that probably we need to combine different therapies. So something that can mitigate the inflammation, neuroinflammation, but on the other side, if the other paradox that we defined in 2015 is true, we also probably benefit from some other drugs that can safely remove the overload of soluble species generated by the disentangling, the disassembly of these plaques. So of course, combination therapy will be interesting to explore, and also some, both targeting A-beta 40 first in order to remove the backgrounding CAA, and then treat with anti-amyloid 42 antibodies in a more safe environment, in order to don't have the already existing CAA that can serve as a seed to accelerate the process because of the sticky property of A-beta.
Yeah, for me to understand. Yes, for me to understand. You're talking about sequential treatment, not in fact combination therapy, right?
It depends. If you use two different antibodies, I think that probably you need to go with sequential treatment. A kind of regulicity from A-beta 40, so CAA first, and then disassembly of the plaques with actual antibody, monoclonal antibody. Or if you use only the A-beta 42 targeting antibody, you need probably to combine with some other small molecule compound, enabling the safe removal or the slowdown of these species that cannot aggregate too fast into the vasculature.
Mm-hmm.
I think we can take advantage that we have Xavier with us and try to ask him also, what could we use from the multiple sclerosis field that we could apply to Alzheimer's disease? Let's dream a little bit, Xavier. I mean, you have great experience. We were talking before, it has some similarities, but from your great experience in MS, what do you think we could apply to AD field?
Well, Alzheimer's also has a clear inflammatory component, right? And you are trying now, as we already discussed, the anti-TREM2 antibodies, and there are trials in motor neuron disease and also in multiple sclerosis as well, with a new anti-TREM2 antibody, which is supposed not to produce so many areas, right? And be more effective. So this is one example. So one single molecule being tested in 3 different diseases. What I said about rituximab is because we have been trying to decrease the side effects of our monoclonal antibodies for a while. And at the end, you realize that using just one small dose of anti-CD20 every 6 months, which is very convenient, you can perhaps decrease the level of inflammatory activity within the CNS. I don't know, the BTK inhibitors, why not? They are also affecting the microglia activation. I'm not sure if you have in Alzheimer's any experience on that, but perhaps you have. But I think there are some similarities with this component. Yeah. Thank you for the question, John.
And Zane, in your case, what you learned from the iatrogenic CAA that you think we can apply to AD, if it's anything? I know it's complex.
Yeah, that's a question I have not received before. In terms of the treatment for, you mean in the terms of the treatment of Alzheimer's disease, what we can learn from the iatrogenic? I think it all goes more.
And even having those young patients we could do things with the blood samples of those patients to, it's like a new model of the disease in a way.
yeah, I think I have two ideas. Two thoughts on that. One thing is obviously, I think the most important thing what we should learn, and hopefully we all have learned it, is the prevention, the issue around the health and safety and the prevention, and thinking already now ahead of about the things which people, you know, didn't think 30, 50, 40 years ago, and just thinking, is there something we are doing right now which is actually iatrogenic or equally detrimental, is one thing. But the other important thing is obviously there is still a huge amount of research to be done, and also to understand really better about the amyloid beta isoforms and the diversity and the range of the isoforms and or the conformations or the species. Do they play any role? Are the iatrogenic cases in any way actually different? You know, pathologically, we don't see with routine approaches any differences, but maybe the isoforms are actually different. And those might tell us more also about the treatments that you are, you know, in a futuristic scenario, you know, 10, 20 years from now, that we will be treating these subspecies, these specific isoforms, and maybe there are isoforms which are more causing ARIA and the others which are not. Maybe there are isoforms which are more prone for having the inflammatory reaction, inducing inflammatory reactions, and others don't. And I think really understanding more about these amyloid beta species, the peptides themselves, including the isoforms, the conformations, will, I strongly believe that there is something important we haven't discovered yet, which will be important for the treatments.
Okay, I think even the time of treatment, no, because we used to say that we give too late treatments to these AD patients, and perhaps there we have an excellent opportunity of starting treatments 20, 30 years before. So for me, those could be, yeah. I know it's strange patients, but it could be something really important to study or demonstrate hypotheses. And in your case, Fabrizio, we have a few minutes only, but you did a great work with the consortia, putting many people together. I think that's important. I was trying to go through this direction, asking also to Xavier, because they did some great consortia. What is your dream on this network you're establishing? What we should do to learn more, to work together?
Yeah, I strongly encourage you and everybody are listening us today to try to join this effort. We are also trying to find funding in order to, in my dream, my wish will be to establish something similar to ADNI, but for these rare forms, so for ARIA and CRI, and to make public all the database of this data that we are generating. Actually, we are testing about 20 different biomarkers, both in parallel in CSF and plasma from the same patients longitudinally. And we also have MRI and PET data and clinical data and data regarding therapy. So not only the anti-beta antibodies, a lot of other markers. So will be a very important resource for everybody. And we also have DNA. So someday when we will better define, we already have the DNA stored in the bank in order to explore if there is something today missing or unknown related to some SNPs pathway or some genetic predisposition. Who's not?
Perhaps on that note, I would like also just to add that it would be also very important to try to attempt the post-mortem examinations and have that tissue collection to really, from mechanistic point of view, to understand better what is really going on, and which will then inevitably enable us to identify the biomarkers and identify the treatments for these patients.
A good point. The issue is that given to the Boston 2.0, but also the JAMA criteria for CRI, clinical and radiological criteria that we also contributed in establishing. Actually, I would say that there are no more brain biopsy, not only autopsy, available for any kind of study. And so I think, and we are also reasoning within the International CAA Association. Actually, we wrote some guidelines or recommendation. We also need to start thinking about new reference standard, because I think the pathology was considered a gold standard, but actually is not probably the gold standard for these diseases, because it's not a routine assay to have brain biopsy in these patients. So we probably mislead something because of the selection bias of the pathological specimen that we have available when we define the criteria. So now the spectrum is, enlarged a lot compared to this. And so we need to find something else. I don't know. For CRI, I think that response to treatment, corticosteroids should be something to implement in new criteria. Or let's see and hope for the future.
So thanks a lot. We are on time. I mean, my summary would be that we can be optimistic on this disease. I think it's a shift of paradigm, and we are starting something really new. I don't know if Xavier wants to close and give some.
On behalf of ACE, we would like to thank you very much for the three of you, in fact, for the great presentations and great discussions. So thank you very much indeed, and have a very good day.
Okay. Bye-bye, everybody.
Thank you. Bye.